Good evening. To be fair, for those on time, including our speaker, and I think the others will trickle in because of the challenge of the location. We had a more cozy room, but we were concerned that NCD is such a big problem, we would have a bigger audience and people would be standing, so we changed at the last minute to here. So it's really indeed my really great pleasure to introduce a colleague, collaborator and supporter of our NCD activities, Professor Walid Ammar, who is, of course, the Director General of the Ministry of Public Health and has been for many years. Under his leadership, reform efforts have been on their way and have led to significant improvement in cutting down on healthcare expenditure, but also improving efficiency and outcomes for major health indicators. I can say that for osteoporosis guideline, the use of osteoporosis medication and BMD testing, we've really achieved strides under his strong support, leadership, and endorsement. His approach is truly innovative, open networking model of governance with collaborations, and really has led to major achievements in our health system. Dr. Ammar is professor at the Lebanese University and is senior lecturer at the American University of Beirut. Our sharp student takes some health policy courses with him and enjoyed it greatly. He has served on the executive board of the World Health Organization 2012-2015, and he's currently a member of WHO Emergencies Oversight and Advisory Committee. Dr. Ammar has published over 100 peer-reviewed papers, book chapters. In addition, has edited 2 major books, Health Systems and Reform Lebanon and Health Beyond Politics. He did not include it in his bio. He's the recipient of multiple awards when we travel the same circles. We know about them in recognition of his outstanding work and achievements in our NCD. And his talk today is to really summarize approaches to fight NCDs in Lebanon. Dr. Ammar, thank you for coming.
Thank you, Dr. Flahan, and thank you for giving me the opportunity to talk about the policy of the Ministry of Public Health facing NCDs. And I will tackle in this presentation the different approaches to fight NCDs. You know, the NCDs are the best example that show that the health system has a lot of limitations, and we need to seek intersectoral collaboration in order to have a significant impact in reducing the burden of disease. Therefore, the Ministry of Health is, of course, responsible to strengthen the health system, but also to play the role of facilitator in order to encourage and coordinate intersectoral approach in order to fight NCDs. Well, fighting NCDs, you know, we need to know what are the metabolic, physiological, and as well as behavioral risk factors and the underlying drivers. You know, the health, the lifestyle has a lot of influence on NCDs, and it is very much related to urbanization and the epidemiological transition that led to the to having NCDs as a major cause of mortality, or the most important cause of mortality, went in parallel with the you know, the demographic transition and the aging of the population. So there are the dimensions to fight NCDs: reducing risk factors, early detection and treatment, and secondary and tertiary care, of course, and health technology assessment is important in this regard, and palliative care. And there are different approaches, particularly global health and international instruments, and I will be giving examples on the importance of using these international instruments, particularly in dealing with the risk factors and the intersectoral action, integration in primary health care, and case management and continuity of care. So as you see that the most important risk factors, tobacco, unhealthy diets, physical inactivity, and harmful use of alcohol are common risk factors too for all, for the most important non-communicable disease, cardiovascular disease, diabetes, cancer, obesity, and hypertension. These are recent data from the recent STEPS survey, where we can see that almost half of the male population is smoker. The average rate is 38%. Alcohol consumption, regular alcohol consumption, 23% of the population. Unhealthy diet, 73%. Physical inactivity, 61%. And 27% suffering from obesity and 58% of overweight. And we have included the Syrian population in our sample. And as you can see, on average, we have, of course, less obese among the Syrian population, but they have also, and alcohol consumption is less important, but they are also suffering from the other conditions. So the prevalence of cardiovascular disease is 8%, according to the sample. Hypertension, 35%, raised total cholesterol, 65%, and diabetes, 10.5%. So, as I said, it's important to design intervention to reduce risk factors in order to reduce premature mortality from NCDs, and it's also, of course, important to to provide services to people suffering from NCDs. So we have, regarding risk factors, we have two policy directions. The first one is strengthening intersectoral action, and then implementing cost-effective interventions that reduce the risk of risk factors for NCDs, and particularly the best buys that were developed by WHO. And we have several tools to implement these policies, including awareness, raised taxation on harmful products, enforce legislation to protect people from tobacco smoke, inform consumer food labeling, and restrict access to harmful products, such as limiting selling time and age, imposing age limits. So these are the best buys. I presume most of you are familiar with these best buys, particularly, tobacco, which is the most important killer. Protect people from tobacco smoke practically by enforcing the legislation that we have issued several years ago. And you know that, it took a lot of time and effort and lobbying with civil society and academia, particularly AUB, Dr. Rima Ash and Dr. Ghazi Zaatari and other colleagues in the Faculty of Health Sciences. And when we got the law effective, so it was implemented for a few months, and then for political reasons and for the interest groups and lobbying and demagogic, politicians, it was, you all know that it is catastrophic now. It's not at all implemented. However, this is not the only thing that that is in this law. The ban on tobacco advertising, it is well respected. This is at least was implemented. The pictorial warning is not implemented. And raising taxes on tobacco, this is very, very important, particularly to discourage smoking among adolescents. And we have, a lot of problem to raise taxes because, different interest groups as well as the Ministry of Finance, they are opposing this measure. The same for alcohol, so raise taxes on alcohol. In the last budget of the government, they mentioned a discrete raise of taxes, and all the lobby of people with interests, and they were, the politicians, they have reduced even the taxes, and we still have much to do in this regard. And you know that some nightclub, they organize parties for adolescents where you pay a flat rate and then you have an open bar and you consume a lot of alcohol. Unhealthy diet and physical inactivity includes reducing salt intake in food, replace trans fat with polyunsaturated fat, promote public awareness, and hepatitis B vaccination to prevent cancer, liver cancer. And you know that hepatitis B vaccination is mandatory in Lebanon, and it is working perfectly for now 15 years. So all newborns are vaccinated against hepatitis. So I will start talking about the contribution of the health system, and then I will talk about the globalization and intersectoral collaboration. So the plan is to integrate NCDs into primary health care, strengthen health system, particularly health financing, access to medicines, health information, and the health workforce, universal health coverage of hospital care, health technology assessment, and promoting palliative care. You know the coverage system in Lebanon, every citizen who is not enrolled in any of the existing public funds is entitled to the coverage of the Ministry of Health. So we have a very good coverage for hospital care. The Ministry of Health does not reimburse ambulatory care. However, we provide an alternative, which is primary health care delivered through a very large network in coordination with NGOs and municipality. And this is a very well functioning system, and we are providing a package of services, and we have an accreditation system. So we have increased accessibility to primary health care, and this is how we were able to reduce out-of-pocket spending in Lebanon. So this is to show you that Lebanon is very well placed in terms of deaths from NCDs before 60 among the Eastern Mediterranean region, and this reflects very well the importance of the health coverage and the importance of the health system. So the integration of NCDs within primary health care is very important. And the goal is to sustainably integrate a two-step early detection of diabetes, hypertension, and estimation of total cardiovascular disease. We have started in December 2012 with the group of patients, half of them from the health centers and the other half, we recruited them from through home visits. It included 5,300 people above 40 years of age. And the first step was a triage based on a questionnaire and screening for blood pressure, weight, circumferences, and glucotest. And then the step one, those with a high risk are referred to the health center to do, further investigation regarding blood sugar and lipid profile, etc., in order to establish the risk score. You are maybe familiar with these charts that determine the risk according to the age, the level of cholesterol, and whether the person has diabetes or not. So we are using this instrument in the health centers in order to establish to follow the protocol for further investigation and follow-up. And this is how we have selected patients based on the body mass indexed, waist circumference, blood glucose, family history, and smoking as the first step. We did it for free. And then we referred patients with risk to the health center for further screening. And this is the results we got. Among the people, non-diabetics, we discovered that almost 10%, they have a high level of blood sugar, although they are not known as diabetics. And among people known as diabetics, a third of them are not well controlled. And the same for hypertension, 16% were not known having hypertension, and almost half of those having hypertension are not well controlled. So the purpose was not really to have statistics about the population, but rather to integrate this practice of assessing cardiovascular risk within the practice of the daily practice of health center. And this is very important. Among the, not all of the 220 health centers within the network are practicing this, but most of them are now familiar with this procedure. So the integration, the purpose is to deal with the disease as a group of disease and to involve multidisciplinary team and to integrate the process in the daily work of the health centers, and to ensure a continuous supply of NCD's essential medicines. We have also a very effective program which is managed by YMCA and financed by the Ministry of Health, and with the contribution of other NGOs, where the medicines for chronic disease is always available. Of course, sometimes we have shortages as these days because we don't have a budget yet. But it is very well functioning, and the program serves 70,000 patients on a regular basis. And among these patients, 23% have cardiovascular conditions, 12% are diabetics, and these are the distribution. 14% have hypertension. So this is the integration within primary health care, I would say the horizontal approach. However, we have, you can look at each disease vertically, and when we consider the cancer, for example, cancer program, so it includes awareness and screening, the famous yearly campaign, which is the breast cancer awareness about the importance of mammography. Of course, it's not a screening campaign, it's an awareness campaign, and now we are starting an awareness campaign about the importance of FIT test for early detection of colon cancer. Early diagnosis and treatment integrated within primary health care, and now we have a program of community-based insurance that we are developing with the World Bank, where we recruit not patients, we recruit beneficiaries that participate in a small prepayment, starting by the extreme poor defined by the Ministry of Social Affairs, and we provide them according to sex and age, preventive packages, including mammography for certain age, including vaccination for children, and all the package, lipid profile, according for each age group, there is a package of for early detection of disease and follow-up. And of course, that the ministry covers chemotherapy, including the most expensive drugs. So some of these drugs are not even covered by wealthy countries, and the problem is that this system is, of course, not sustainable, and we are experiencing shortages and in drugs. And we cover surgery and radiotherapy. In addition to that, we subsidize certain centers of excellence. The Children Cancer Center at AUB is one of them that are subsidized by the Ministry of Health. And the cancer registry is part of this cancer program. So this is to show you that we can consider a disease vertically, whereas we have a horizontal approach through primary health care and intersectoral approach that I will be talking about. So why globalization is important in this regard? There are international agreements, particularly related to commerce and trade, and all the harmful products that we are talking about, they are protected by this agreement practically. These international agreements, they supersede national regulations. So it's really very important to know how to deal with these agreements. So this is the negative side of globalization. On the other hand, there are international instruments that are developed globally that are done to enhance collaboration between countries to face certain disease. Particularly, we have a good example, the Framework Convention of Tobacco Control. I will be talking about this in a moment. And of course, there is the famous paragraph 4 of the Doha Declaration that stipulates that the TRIPS agreement does not and should not prevent members from taking measures to protect public health and promote access to medicines for all. This is, there are very few countries, such as India or South Africa, that were really able to use this paragraph. Most of the countries are not able to use this paragraph, and all the agreements regarding trade, you know, free trade between countries are very powerful. In addition to that, they create, you know, interest groups in the country that would face any kind of regulation regarding harmful products such as alcohol or sugar or tobacco. So the purpose of the WHO was interested in mobilizing the international community and to create frameworks to facilitate coordination between countries. At the same time, to use this framework as a framework of accountability for political leaders to achieve certain goals as SDGs. So these are examples of the international treaties or declarations. The Rio Political Declaration on Social Determinants in 2011, the Moscow Declaration regarding NCDs, and of course the Sustainable Development Goals stipulating that by 2030 we should reduce by 1/3 the premature mortality from NCDs. So these, the importance, as I said, is to create a framework of accountability, to create, first of all, commitment of political leaders to face NCDs, and at the same time to put targets and to create an accountability towards the local population, but also towards the international community. This is the purpose of these kind of agreements. This is a successful example of an international instrument, which is the WHO Framework Convention on Tobacco Control. And Lebanon was among the first countries that signed this convention. And why it is important? Because, you know, if you want to ban advertising, tobacco advertising, considering the telecommunication and satellite broadcasting, it is useless to do it in one country because, you know, you have other, you know, advertisement broadcast from other countries. And when we tried to issue a law on smoking in the 1990s, we were not faced by the tobacco companies at that time. We were faced by advertising companies and the media. So because this was a way to generate a lot of fund. So the Framework Convention is an international tool where all countries would ban advertising at the same time to be effective. Okay. Otherwise, no country would do it by itself because it's meaningless and it would harm its economy. The same regarding taxes and smuggling. If you raise taxes and in other country, the tobacco is very cheap, so you increase smuggling. And so you need this. This is an example. This is why international conventions are really important. And based on this convention, we issued the law in Lebanon. So this is the global dimension of the NCD. Now, regarding the intersectoral coordination, as you know, the social determinants of health, they are important, influencing the health of the population, but they depend on other sectors than the health sector. So there are other authorities than the Ministry of Health that are concerned with these issues. For example, education. Education is the most important factor influencing, for example, education of mother influencing child mortality, and it depends on the Ministry of Education. So school health, for example, is important. It depends on the Ministry of Education. Working environment, water and sanitation, and housing. So there is a need to have a coordination among all sectors and to introduce the concept of health in all policies. So in every ministry should have a health component within its strategy, and the Ministry of Health is responsible to facilitate this process and to introduce this. So although it is outside the health sector, it remains the responsibility of the Ministry of Health to play as a catalyst to improve this. And the NCD's national plan, Dr. Salim Adib, he played the major role in developing this strategy for the Ministry of Health. It is based on reducing vulnerability to NCDs, optimizing care and prevention, monitoring epidemic progress and trends. So I will not go into details, but this is an example that shows where we have clear interventions and strategic objectives and expected outcomes, and who are the partners involved in each action, to say that it goes beyond the Ministry of Health. For example, healthy schools, the Ministry of Education is involved. Healthy city and healthy villages, the environment, the municipalities and the Ministry of Interior are involved. So these are just examples to show you that the plan provides for intervention of different ministries. So this is to summarize how each action, for each action you have to involve other partners. Reduction of salt in addition to the Ministry of Health, the Ministry of Economy and Trade, the Ministry of Interior, and the academia, of course, for research. Marketing restriction and fiscal interventions on unhealthy foods. Again, Ministry of Economy and Trade, Ministry of Interior, and Ministry of Finance, and etc. So you can see that in every action we are involving, and as you can imagine, this is very, very difficult in Lebanon. So to understand the importance of risk factors that are not, they do not have only a health effect, such as disability and death. If we take the example of alcohol consumption, it incurs a high social cost, including car accident, divorce, and murders. So everybody should be involved in fighting, in helping in this strategy, because it has also implications that that go beyond the health sector. And this is an example that shows clearly to act on alcohol. There are different actions that involve other many partners. This is another example. We don't have to go into details. So the fiscal policies, up till now, it was not really successful to convince the Ministry of Finance to impose taxes on harmful products. And we tried to impose, earmarked taxes, sin taxes, that could benefit the Ministry of Health budget, because we are suffering from budget deficit for years now. But, there are other priorities. and if they want to increase taxes, in general, they have other projects to do than health, so it's not really easy to convince them. I have one example, and that we are proud of, is how we were able to involve actors, all the concerned actors, in the substance use response. And as you can see, you know, we have been working with the Ministry of Social Affairs, Education, Ministry of Justice, Ministry of Interior and Municipalities, the NGOs, academia, and private hospitals in the area of prevention, treatment, rehabilitation, social integration, harm reduction, supply reduction, research, and advocacy regarding. So we did all this exercise, and we came up with an interministerial substance use response strategy for Lebanon 2016-2021, including all these actors. So everybody were involved in developing this strategy. This is, you know, a good example and it works very well, because from the beginning, it has been a long process, but from the beginning, everybody was involved in elaborating this strategy. I guess I can stop here to have time for discussion. Thank you.
Really, thank you. This is an eye-opener because we sometimes come across these intersectoral, global, and determinants of health. We're all aware of that, but in our little niche or corner of diseases, I think this is really very exciting and an eye-opener to some of us, and certainly our younger faculty. I'm going to open the floor for questions. I think we can speak loud. We don't need a microphone. Open it to any questions. Hello?
Yes. Thank you, Dr. Ammar. I'm an endocrinologist. My name is Manal Nasrallah. And in the data that you presented, the physical inactivity was 60%, which we also notice it a lot among our patients. And that's a major risk factor for diabetes and other NCDs. So I was wondering, what are concrete steps that is being done with this collaboration with other ministries to increase the physical activity? It's because I don't think it's a matter of awareness, but of opportunity in the current urban setting.
Well, we are working a lot with the Ministry of Education, and it is part of the school health. So this is important, and we put a lot of effort to develop the concept of healthy cities and healthy villages. And we had experience with certain villages in this regard. But you know, we didn't do anything that is spectacular beside these two examples.
I have a question on the package, the first step, second step, to capture in a horizontal manner multiple risk factors, hypertension, diabetes, obesity. What is the penetrance in the map you showed us of Lebanon, of how many or what proportion of subjects going to the health centers are actually being screened in step 1, and more importantly, coming back for step 2 if something is detected that needs further work?
You mean the sample that
You showed us how this works, right? You showed us 200 something, and the first step is doing the blood sugar, the blood pressure, the BMI. And then if there is something, they go on to step 2, which is a more in-depth evaluation.
Yes.
Is this being implemented now?
It is implemented.
Okay, so what proportion of patients coming to your primary healthcare center in Lebanon are getting step 1? And of those getting step 1, how many of those targeted to have step 2 actually come to step 2 to be evaluated further?
I'm sure we have the data on this because we have a very good monitoring system. I showed you the sample that we did at the beginning. But you can have these numbers from the
Because I think, I mean, we talk about what we do as healthcare providers. I think in any chronic disease, we counsel patients, we detect, we advise. But sometimes there are mixed messages from various physicians, specialties, media, public, TV, about whether this is a priority or not, whether this is the right way to go or not. And the same way you talked about education, finance, etc., we need to be more global in educating our patient in a cohesive and coherent manner, where we're not giving these messages for them to comply. Because you could do the screening, you can identify the risk factors, you could say, come to step 2, they never show up.
Yes.
And we would have spent enormous energy trying to do the step 1, but if they don't come to step 2, these are the really ones who are hurting. Of course, step 1 is important. We have defeated our purpose. This is why I was asking the question.
Yes.
And there is a lot of frustration in our practices when we advise. For example, I'm going to give a very simple example. Dr. Shahtoura was involved with me. The hip fracture liaison service at the UB. For the last 3 years, we've been trying to identify hip fracture patients at the UB and get them to do the simple stuff in the hospital. A vitamin D, full assessment, BMD, and refer for treatment, as they wish. Our response rate from physicians and patients have been appalling. And hip fracture are the most costly fractures, as you know.
Well, let me tell you that theoretically the health center is supposed, if someone doesn't show up, the health center is supposed to reach for him and to call him and to visit him at home. And this is the importance of working with NGOs. And there are some centers that are doing this excellent work. Not all of them, of course, but because they don't have the same capacity. And this is the importance of having this kind of collaborative governance that you mentioned in the introduction, where the Ministry of Health and the other ministries as well, we do not have enough resources, whether human or financial resources. And we should, and we were able to do that, we should capitalize on the existing resources in other sectors. We have a strong relationship with the academia. You are one example. Dr. Abla Sbai is another example. We count on people in academia to provide evidence for policymaking and to evaluate our program. And we were capable through this network of NGOs and municipalities to not only to steer the system towards by defining standards for quality and packages, developing guidelines, training them, but also to capitalize on their resources. We are using also, in addition to the resources of municipalities, we are mobilizing the resources of NGOs and municipalities. And the advantage is that we are working with people from the community, so they know the community, and they can, recruit the people that need particular care.
Is known to be a leading cause for NCDs, and WHO reports that it causes almost over 13 million deaths every year. What is the Ministry of Health doing in terms of linking NCDs to air pollution? That's the first question. And the second question is that, would you be able to share some of the data that you have so that we do the job? That means we take where these people live and try to see whether there is a link between cancer patients, for example, and air pollution.
Yes, of course. The information generated by the cancer registry, everything is published, and Dr. Salim Adib is following closely on this issue. And we try to have a representation, a regional geographical distribution of this. But this is really difficult, and we every time we are facing the difficulty of because the reporting is done by according to the facilities. The distribution is done according to the facilities that have reported the disease, not the residence of the patient. But we are trying to improve this. However, to answer your question, the data is there and it is available, particularly for researchers to use them, of course.
What about air pollution?
Well, you were the one that raised this issue and that motivated the whole, mobilized the whole ministry, particularly the minister, to highlight this important issue. Again, the resources of the ministry are really, really very limited, and we are happy that we are being able to achieve a lot in coordination with the academia, NGOs, private sector, and all of the other stakeholders.
The best buys were actually fiscal policies.
Yes.
And we seem to have experience of having tried to move forward taxation policies for tobacco and failed, right?
Yes.
And I was wondering whether there are lessons learned from that process, where thinking forward about integrating fiscal policies for example, unhealthy foods, where we can almost preempt the actions that would come from these interest groups that you were referring to. And if there are lessons that we can learn from other contexts that have been successful in implementing some of these policies. I know we say our political environment is difficult, but many countries in Latin America have difficult political environments too, in terms of the interest groups that are extremely powerful. So the power of the industry is similar globally, and yet some countries have managed to implement taxation policies. Mexico, sugar tax, for example. And so I'm just wondering, are we actually looking, since these are the best buys and they're listed on all of the harmful products, are we documenting lessons learned to try to see if we can preempt some of these actions and if we can move forward some of these fiscal policies?
Yes, it is documented, and we have an interesting experience with the law on tobacco, because we were able to mobilize the academia and the NGOs to face, the other lobbies, and we were able to have the law, to pass the law. And when the law was effective, and everybody went at home, and we found ourselves alone. And now they realize that they are needed not only to issue a law, to design the tool, but also to implement it. The only way is because, these are best buys because they do not cost, because we have limited resources, and they have a great impact, particularly on adolescents. And these companies, whether tobacco or alcohol, they are targeting particularly this age group. And I would say the only way is to have, for the Ministry of Health, to have allies and to lobby for this. Because this is how, restaurants and hotels and the others were capable to freeze the implementation of the law, because they put pressure on the politicians. And we were not really capable to face them. We didn't have enough strong allies to face them. في دكتور صباعي هونيك تفضل.
Thank you, Dr. Rahman. Can you hear me?
Yes.
So I have a comment, and it's a kind of paradox in my mind. So life expectancy in Lebanon, whether these are real estimates or guess estimates, or guess estimates, have been increasing in the past 10, 15 years.
Yes.
You read in the books, international statistical books, that life life expectancy increasing? I mean, I'm sure it's not it's because of the only interventions among the young. So I'm pretty sure it's among interventions among the old, middle age and the older population. So has there been an attempt to see where we have failed so far, or where we are doing a good job to the extent that this life expectancy is increasing, and maybe a comparison between the two-step surveys is opportune now?
Yes. Yes. You know, the pharmaceutical firms, in order to promote these very, very expensive drugs that prolong life for a few months, they were, you know, taking the example of Lebanon, how Lebanon was capable to improve its life expectancy. And because we have open access to immunotherapy and et cetera. So this is ridiculous, and I had to explain this in a conference. You know, we were capable to increase our life expectancy, and this is an average. Okay? When you save more lives at a lower age, because we were capable to decrease child mortality from 35 per thousand to 9 per thousand, this is significant, and this makes a lot of impact. We were capable to reduce maternal mortality significantly. And so when you save lives at a young age and among children, you have a high impact on life expectancy, much higher than, you know, increasing by few months the life of those suffering from cancer, etc. But also, we cannot deny the fact that we have a very good medical institution, and we are providing a good quality of care that also improve life expectancy, but mainly because we were capable to reduce child mortality.
I think I'm sorry if I may just answer this because it's related with that. I think what's been the buzzword for the last 2 to 3 years is implementation science. It's us doing what we're supposed to do when we take care of patients, following guidelines, following the packages, the first step, the second step. And I think what Dr. Sbag was alluding to, it would be really fascinating to look at, is are we doing a better job in screening NCDs and addressing NCDs between step 1 and step 2? That would be a fantastic project. I think it will take some analyses, but it would be fascinating. And I'm sure, you know, if the data is available, it could be explored. Anyway, Dr. Edi.
Dr. Ammar, I think that you would agree that compared to the progress that we have made on communicable diseases, mental health, and other issues, financing healthcare, I think we have not been able to make as much progress on NCDs as we would have wanted to do. About 20 years ago, we had an NCD program that had been established by the MOPH that was dedicated to governance
And that
coordination. It doesn't matter. I wasn't the only one. But the issue is that we had a program, and the program disappeared. And we wrote a plan. Number one item, governance and defining someone who can run this issue. Where are we in terms of pushing this first item that is the key to activating a plan rather than to plug in issues like that we can?
Look, when I came to the Ministry of Health long time ago, 1993, the number of staff at the ministry was 2,600 employees. You know how many we are now? Less than 1,000. From 2,600 to less than 1,000. You know, what's the number of employees in in one hospital? It's around 3,000, I think. See, the whole ministry in Beirut and all districts, we are less than 1,000. This is to show you that there is no political will to strengthen the public sector. This is the answer, and this is political, and this is the answer. But we were capable to build a team, you know, using different resources, WHO, World Bank, sometimes UNICEF or other people. And we were capable, most of all the good work we are doing, and we are doing good work. And if you see, there is a recent study that will be published, in the Lancet about access to quality care. And Lebanon is ranked 32. And this is the fourth international study that ranked the health sector in Lebanon among the first, 30 or 35 countries, using different methodology, using different indicators, and we are, as a health sector, we are doing very well. And how we were capable to do that? Because of this collaborative governance, because we are not relying only on our resources, we are mobilizing other resources, and we are working with other people. And many people here know that they can work with the Ministry of Health, and they have an input to the Ministry of Health. And this is how we are capable to achieve. And we were capable to build a small team of professionals at the ministry, and it's not easy to protect them, to tell you the truth. So the problem is political, and how the politicians look to the public sector and what would be and what they do not understand is, if you want to privatize, you need a stronger public sector, not a larger one, a smaller one, but a stronger one. And this is, they do not realize anyway. This is not the only problem in the country.
So there's a lot of NGOs in Lebanon that are working on cancer awareness. But where is the Ministry of Health working on prevention methods, more screening tests? We don't see it being implemented much in Lebanon.
Yes. So what I explained, what we are trying to integrate within primary care is early diagnosis, early detection, early diagnosis, and early treatment. This is what we are doing. But at the national level, we are doing some campaigns in collaboration with NGOs and the media. And of course, the NGOs working in this field, in the field of prevention and promotion, the NGOs are the best allies of the Ministry of Health to do this work.
I think Dr. Ammar identified two screening. I think breast cancer was one of them where the ministry is more active, correct me if I'm wrong, and the second one on the horizon or being implemented is colon cancer, which are...
Yes, but also early detection of NCDs that is practiced in the yeah.
All right, I always try to see the positive and the negative. So Lebanon used to rank number 100 in corruption 10 years ago. Lebanon ranks 143 in corruption now. So if we're able to be ranking in the upper tertile in research publications, academic achievements, and in quality of cares, I think there's a lot of credits to the individual who have been partaking in it. And I always joke to my American and European colleagues, say we should get extra credit because we're doing it despite all the challenges. So I really think the people here are the people who are excited and passionate about improving health. I think Dr. Ammar has been an ally for many of us who have been working in this field. I want to thank him for his time. Thank you for coming. This is going to be taped with your permission, available on the SHARP website. And we hope some of us will approach the ministry to access data and do research that's relevant to health. Thank you so much.